Alrighty, good morning, folks on Zoom. Alright, I'm just checking off everybody on Zoom and then we'll go ahead and get started. Thanks everyone for your patience this week as I dealt with my family emergency. So my husband, while I was out of town, started having really bad pain, rushed to the hospital. He had to have 2 different surgeries. He has down 1 gallbladder now. And he's doing better, but he can't really function on his own yet. So I have been trying to support him in whatever way I can. And so even though I was caught up with grading last week, it means I haven't done any grading this week. And so thank you for those of you who have been patient. Thanks for those of you who reached out and offered us words of support. He is home now, which makes all the difference in the world. And recuperating, and hopefully this will never happen again. Poor guy. But my daughter is good. The cats are happy he's home. So, we roll with the punches, right? Alrighty, so I don't know how many people got a chance to review the slides on video from the last time I taught this class. But what I'm gonna do is, that's right, sorry. One of these eons I will remember. I can only turn off the captions when I'm not screen sharing. There we go. Now you'll actually be able to see the whole slide. But so what I'm gonna do is if you want to see the videos, you can go in to that, or you just click on them from the slides, honestly. But I want to make sure you all have the information from the lectures, so I'm going to be covering that. And then hopefully we have an activity today. If not, we'll do it Monday. Alrighty. So the first talk therapy, if you remember Monday, we were talking about the bio ways we can treat disorders. So medication, surgery, TMS, ECT, all that kind of fun stuff. The first talk therapy was psychoanalysis. And Freud studied with a man who was doing hypnosis with his patients. And while the patients were under hypnosis, they would talk about their lives and they'd wake up feeling better. And Freud said, what if we did that, but just didn't bother with the hypnosis? We just had people talk. And so that's what he did. And this was the first talking therapy. Free association was just having patients talk about anything that came to mind. Resistance was refusal to participate fully in treatment, and you would spend a lot of time processing that. And this is something you do in any type of therapy, honestly. So if a client is consistently late or missing appointments or doesn't do their homework, you process it. You figure out what's going on, what's getting in the way, right? And sometimes it's just life, but sometimes it's I had a client once tell me, I thought your homework assignment was stupid. And I was like, cool. You still got to do it, right? Transference is when the client or the patient redirects their feelings towards the therapist. So they might feel romantic feelings towards the therapist, or they might see the therapist as like a father figure or a mother figure. Countertransference is when the therapist expresses their own feelings towards the client, perhaps related to things in their own life. So, let's say you're treating an elderly patient and your grandmother is sick, you might be like extra caring towards that elderly patient. Catharsis is just feeling like you got stuff off your chest. So on The Sopranos, Tony Soprano talked about going to therapy as like taking a shit. It's like just getting stuff out. And of course, Freud was very into dream analysis. And he would examine the actual stuff people dreamed about and analyze it to get sort of underneath that. What's going on? Currently, dynamic therapies tend to be shorter term, largely because that's what insurance will pay for. And there are also relational psychoanalytic therapies that focus more on things like attachment to your original family of origin, to your romantic partner. This picture down here in the corner is the actual couch Freud just started this therapy on, and you can see that the therapist would sit behind. And the idea was the therapist was a blank slate. The client couldn't even see them, and therefore they could like project what they were thinking onto the therapist. And again, you can watch these videos later, but they're a nice little depiction of things. Let me make sure the world isn't ending. No, it's just notifications. Okay, you're going on silent. There we go. Let's see. All right, good morning to folks who are joining late. Humanistic therapies were developed by this gentleman down here. His name is Carl Rogers, like spelled like Mr. Rogers. And the emphasis of this approach was self-healing. So you wanted to focus on conscious thoughts rather than psychodynamic, focused a lot on unconscious impulses and trying to get the person to self-fulfillment, to be the best they could be. And the goals of therapy were understanding yourself and personal growth. And so this was very non-directive. It was a lot of self-exploration. It was a warm, supportive atmosphere with active listening and reflective speech. So what that means is like the therapist really paying attention to the client and sometimes even like repeat back what the client said, sort of paraphrase it to make sure, like, am I hearing you properly? That type of thing. Another big aspect of this therapy is unconditional positive regard. So Rogers believed a lot of people never got unconditional love. That like people in their lives were sort of contingent, like I'll love you if you do well in school. I'll love you if you're the best at your sport, whatever that particular contingent was. And Rogers thought that in therapy, you should offer your clients unconditional support, unconditional lifting up. And so this was a big goal of the therapist. And so you wanted to be really empathetic, but you also didn't want to fake it. You wanted to be genuine. Clients can tell when you're not genuine. And Rogers thought, well, in order for them to like buy into everything, you should actually like be genuine. And I'm going to show just a teeny snippet of Rogers just because his style is so unique. So I'm going to skip forward a little bit in this video. And you'll see Rogers working with this gentleman.
Talk a little bit about what's going on in my life, which is my ongoing agenda, I suppose.
They made it. The agenda is kind of scary.
Yes,
Mhm.
I feel really very exposed and self-conscious.
Mhm.
But I also feel that some part of me is delighted to be sitting here in front of you and talking to you.
Mhm.
I'm a little distracted by some noises behind me or a rumbling. I don't know what that is.
I think that's outside, I don't, anyway, let's try and disregard that.
Okay.
Let's get forward to the guy actually talking about what's going on.
2 days ago, I did a lot of intense work in a small group, ventilated a lot of pain and talked about what's going on with me and got some excellent support from my group. Right now, I'm feeling a little strange about repeating what I just said at that time.
But no, whether that's the place to start or not, but at least that was helpful to you again.
Yes,
Really got some things out.
yes. Feeling sad that the workshop is going to end in about 24 hours. Feel, with respect to many people here, both a strong connection and some pain that I haven't spent more time with various individuals, ambivalence. And now I'm feeling awkward because I feel as though it's my task to produce something to talk about. And I'm not quite sure what to do with that. Great, making a decision, but
And so what you saw Rogers doing there was what I would call the therapeutic pause. So sometimes your client will stop talking and they just need a second to like keep processing things. And Rogers and a lot of good therapists are really good at not jumping in, right? Not feeling like they need to, oh, there's a pause, I need to jump in. So you give the person time, maybe you just give them a and then you can reflect back once they get out what they're focusing on. So, and again, Rogers' style is very unique. Personally, I think Rogers would have been an excellent therapist. He's just got a great demeanor. So as we moved forward, as people started to really not like Freud's theory because it was Freud's therapy because it was tied so much with his theories, right? So he would be like trying to analyze the Oedipal complex. A lot of folks were like, this is BS. And so they tried to come up with other things. And so there were treatments built off of behavioral principles that we just talked about for personality. And these focus on behaviors that are causing the problem, and they almost don't care why those behaviors form. All right. So you a lot of times are doing some sort of exposure here. So a lot for anxiety, this therapy is used, but it can also be used specifically for OCD, PTSD. We even do exposure sometimes in therapy for eating disorders. And exposure is exposing someone to what they are afraid of. Right? So for someone with a phobia, that might be a snake. For someone with OCD, exposure might involve putting a little glob of peanut butter on their hand and not letting them wash their hand. So they see it's okay. For someone with PTSD, the exposure is often what we call imaginal, where you have the person either write out or say out loud the story of their trauma. And the reason you do this is a big part of what keeps PTSD going is people avoiding even thinking about the trauma. And then it gains this like weird power over your life. In eating disorders, it might be eating a meal and then having to sit with your therapist and not being able to go to the bathroom and purge. And so you can do this in two different ways. One is called flooding, where you just expose them to the thing they're most anxious right away. Typically, you're using what's called systematic desensitization. And this is where you work with the person to create a hierarchy. What is the most terrifying thing for them? and what is something that's maybe not so bad. So for example, for someone with a snake phobia, holding the snake might be the top of their hierarchy. But maybe like, let's say the snake was where the computer is in a tank, right? Maybe you could like stand at the door and look at the snake, right? And feel like kind of okay. And so you want to start there and then work through it with the client, getting closer and closer and closer. A lot of times this type of therapy will include modeling or observational learning, where you work with the person by you yourself engaging it. So maybe as a therapist, you also put the peanut butter on your hand, or you also work up to holding the snake with the person so they see it's okay. Or you also, sit and eat a meal with your client. And like I said, you start very low on what scares them. So for example, for an eating disorder client, that might be, we'll start eating what you consider to be a healthy meal together, an acceptable meal, right? And then we're gonna work up to you and I sitting and eating donuts together, right? And maybe that's a food that always makes them run and purge. But we're gonna sit and let it digest and realize it's okay. You teach them various relaxation techniques before starting the actual desensitization. So it might be deep breathing, it might be muscle relaxation, something they can do when they get really distressed in the moment, to help themselves calm down, and then they can stay in that moment rather than avoiding it. Right? So if you're someone very afraid of snakes and we've done systematic desensitization and we've got you worked up to like the snake is there, but you can be here, right? If you get anxious and you start to tense up and you just hightail it out of the room, right? That's not gonna be helpful. And so instead, you give them a technique to help them calm down, and then they can stay in the moment and learn it's okay. So the whole point of exposure is learning it's okay. This thing you've been avoiding, it's not gonna kill you, right? And so obviously the snake you'd be using would be something non-venomous because you literally don't want to kill yourself in compliance, right? So some sort of boa constrictor is typically what they use. Some problems with this treatment, criticisms that they get, people say that it's too simplistic. It's assuming that everything is pure behavior and the thoughts you're having or the feelings you're feeling about it aren't important. And so, and also one of the problems that happens is, if you're doing this treatment just in your office as a therapist, the client may be great at doing it in your office. They might even work up to like holding the snake in your office, right? But then they go out and they're gardening and they see a gardener snake. That's a totally different situation. It doesn't, what we call, generalize to other situations. So one of the things people will do is have folks do what are called in vivo exposures, go out and do stuff in other parts of your life. So maybe you go to the zoo and look at a snake, right? Maybe you go to someone who has a pet snake. If you're on campus, you go walk through Greer and look at the snakes, right? So that you're getting used to it in various situations and it can start to generalize. And oh, this is something cool. Again, a video y'all can watch later if you want. One of the really cool things they're doing now for phobia and also for PTSD in particular is VR treatment. And so rather than actually have to have every object or animal, right, that your client may be phobic of in your office, you can program it into a VR set. And I don't know if you all can see, but these are the ones you just clip your phone into, right? So you don't need as much equipment. And they can be exposed to it that way. And it's just as effective in a lot of cases. And one thing that's really interesting is they've started using this for PTSD as well, particularly combat veterans. They can actually essentially, and it doesn't look totally realistic, but it looks like a video game. They can recreate your traumatic situation and you can be exposed to it that way. And again, it's very effective. And as you can imagine, especially folks around y'all's age or teenagers or kiddos really like this, right? Because it's cool tech. In addition to being a way to help them feel better. Here's an example of how you might help someone who had test anxiety. And so this is their list, their hierarchy, right? Of like, what is the least scary a month out from the exam? What is the most scary? Actually being in the process of taking the exam, right? And so as a therapist, you would find ways to replicate these feelings, right? And replicate these situations so that your client got used to it. And when they actually get to the test, they've like practiced, right? And so this isn't as overwhelming. This isn't as scary. There's also something called aversive conditioning that we can use. The classic example here is with alcohol. And so the idea is sometimes instead of like trying to get a person to interact with something more, you want them to interact with something less, right? So if someone has alcohol absolutely destroying their life and their health, they want to get better. Maybe they've tried other treatments and they're just not working. You can use behavioral conditioning with some medical help to basically make alcohol so unlikable to them that they won't want to consume it. So, and it uses that basically classical conditioning. So we've got our unconditioned stimulus, and in this case, it's a nausea-inducing drug. The most classic one used is called antabuse. And then the unconditioned response to this actual medical pill you take is that it makes you nauseous, right? And so then you pair a previously neutral stimulus, alcohol, with that unconditioned stimulus, the nausea-inducing drug, that antabuse. And so now you've drank alcohol and you get nauseous because you've taken this drug. And so once you do this pairing enough, just like Pavlov's dogs, right, with the food, you actually, when you drink alcohol, even without taking the antabuse, without taking that nausea-inducing drug, you will get nauseous from drinking it. And this is not like you're 12 shots deep, so you throw up because you're drunk, right? This would be like a couple sips and you feel nauseous. And for some people, this is the only way they can stop consuming something that they're addicted to. Another example of aversive conditioning that they will do is they'll use it for things like pedophiles. And so they will pair something aversive like an electric shock or something else. There's a case study that my clinical psych class reads where there's a man who's a pedophile, and what they have him do is imagine like his own child being abused. And like that is obviously pedophiles are weird in their hypocrisy, right? Like they don't think about other kids being somebody else's kids, right? But like if you can get it personal, like he was really horrified by the idea of his own child being abused, right? So you take something that like normally would make that person feel awful, again, whether it's the UCS is thinking about someone being abused or actually applying an electric shock. And then that would, again, produce some sort of like aversive reaction. And then you pair that with either imaginal exposure, thinking about abusing a child, or sometimes I've done this with actually showing child pornography images. And then they give the pedophile a little buzz every time they look at them. There have been cases where they've done this by actually applying the electrical stimulus directly to the genitals. So, yeah, don't know how effective it actually is, but it is a case where it's used. So we just talked about how you use classical conditioning techniques. You can also use operant conditioning, which involves reinforcement. And so this is where you might help people unlearn maladaptive behavior or learn adaptive behavior. So applied behavioral analysis is typically used with kids who are neurodivergent. And so they positively reinforce adaptive behaviors, and by sort of ignoring maladaptive behaviors, they extinguish them. It doesn't depend on understanding why the kid is doing it, or the kid even understanding why they're doing it. And so ABA is pretty popular. One thing I will say is that although lots of people find ABA very helpful who are neurodivergent, some people do not. And some people are actually traumatized by this therapy. And so just like any other therapy, it's not one size fits all, but here I think we should proceed with like even more caution and always be checking in with the client. All right, so obviously this pure behaviorism just wasn't working all the time. And so we needed to find ways to expand upon that. And so the conference I was at prior to, my husband's gallbladder rebelling against him, was actually about behavioral and cognitive therapies. And some of the big figures here were Albert Ellis and Aaron Beck. And they basically said, okay, this behaviorism stuff is great, but what about how people are thinking? What about how people are feeling? How can we help them with that? And these two guys basically came up with these theories at the same time. So Albert Ellis developed rational emotive therapy. And this consists of helping people to think more rationally. Even thinking like sort of more scientifically is a way to think about it. It also helps them to like experience their feelings, maybe even like react more emotionally appropriately in certain situations. And then also there's like a behavioral component to these therapies. So you help people to act in more functional ways, just like you would with pure behavioral therapy. So you eliminate irrational and self-defeating beliefs through rational examination. There's a part of RET that's actually called disputation. So it is a little like argumentative and persuasive, but you're not like arguing with the client. You and the client are arguing against their irrational thoughts together. And then Aaron Beck came up with cognitive therapy, and he initially developed this for depression. So something really interesting about Beck, and actually Ellis as well, is they were both trained as psychoanalysts. Basically around this time, you wanted to be a therapist, you trained as a psychoanalyst, right? So like they were coming of age in the 50s, 60s, and like, yeah, behaviorism and humanism were like kind of becoming a thing, but like 9 times out of 10, you wanted to be a therapist, you trained as a psychoanalyst. And Beck would be doing dream analysis with his depressed clients and realizing that in their dreams, they were like beating themselves up, thinking horrible things about themselves, sometimes like betraying themselves in horrible ways. And so he started to talk to them when they were awake and realized they had a lot of these self-defeating, self-hating thoughts while they were awake as well. And so he thought, well, what if we target those? Of course, people are going to feel depressed if they're always beating themselves up and they think they're a horrible person, right? And so he talked about cognitive distortions, seeing or thinking of things differently than they actually are. And then he talked about sometimes these thoughts being automatic. It's not that the depressed person sat there and thought, how can I beat myself up today, right? Instead, these thoughts would just like pop into their heads. And he talked about this negative cognitive triad. So not only did people with depression have a negative view of themselves, but they also tended to have a negative view of the future and the world around them. Cognitive therapy is reflective. It's a little less confrontational, but you certainly do question your rational thoughts, these automatic thoughts. And there's a lot of open-ended dialogue. And both are more effective in treating depression than medication. And in fact, when you combine either of these therapies with medication, it's basically like the best treatment possible. Oh, and I should say, Beck is the one with the bow tie, the other guy's Albert Ellis. And as you can see, they weren't like adversaries, they got along really well. Again, I'm gonna show just little clips of them so you get a flavor for what these guys looked like doing therapy. Because it's, again, really different than what you might think of as therapy. Alright, so here is Ellis.
Probably wrong, your case. What if I did the wrong thing and you? Or we looking for 3 hours or so. So there's no evidence you did the wrong thing. Even if you did it, sort of reach that time. You're not omnipotent, you can't tell in advance. So you're saying, one, I did the wrong thing, which is, as far as I can see, an error. And then two, I'm no good. I must not, should not do that wrong thing, and I'm no good for doing it. Are you? Did the wrong thing and let them down, which I don't think we ever will be able to do. But let's suppose that that would be a mistake, a serious mistake on your part. But you're a fallible human who makes mistakes. And when you're guilty, you're saying, I must not make a serious mistake, I must not, and I'm no good for doing what I must not do. Isn't that so?
So you can see it's not unsupportive. He's not like trying to beat her up. He's trying to stop her from beating herself up, right? But it's pretty confrontational, right? He doesn't let people kind of get away with things. And so now, again, a small clip of Beck. For context, because I don't remember how much of the story comes out. This woman is in the middle of a separation from her husband.
Suppose David went away, there's a war going on, and went away for an indeterminate period of time. In fact, you wouldn't even know that he was coming back, because happened during World War II. Husbands went off, and nobody ever knew when the war would be over. They're gone indefinitely. And in many cases, indeed, the husbands did not come back. Now, if you're in that position of having lost David through his going into the service for an indeterminate period of time, no assurance that he would ever come back, do you think you would feel depressed the way you do now?
He wants to stay with me, but he doesn't want to be with me. That's different, that's different, like if it's a war, then it's not like David is making that decision, or he's making a decision. You see what I mean?
Exactly.
It's not the same thing.
Exactly, you're absolutely right. See, at first, it looks as though your big problem is the loss. You lost your best friend, you lost somebody to sleep with, to hold you, you lost somebody to talk to, and somebody to love. And yet, when we say this could happen if you went into the service for a determined period of time, you'd say, well, you'd miss him, but you wouldn't get depressed. So it isn't simply a matter of you not having somebody to talk to or somebody to love. The thing that's getting him down is the fact that he chose it this way.
Yeah, you were choosing.
So David rejected me. What is that?
So he starts to get at these like really core thoughts she's having about things. And so you can see he's very much like scientific, let's write things down, let's rationalize them out together. Whereas Ellis was like very much personality and let's confront this. And
Back you. David rejected me. And David doesn't love me. You really believe that? No, you think that's fair? I don't love him. So there is a supreme arbiter who's lovable in this world and who isn't. Is that correct? David said it like me, they should go into acute depression.
And so you could see humor is used in both gentle humor, right? He's not trying to like undermine her, but he's trying to like help her see beyond the situation she's really mired in, which can be really hard for people with depression. Again, highly recommend y'all go and watch these whole videos because these people are masters at their work. So this is the idea behind essentially both rational emotive and cognitive therapy of like what's going on. And the idea is people think I had a situation. In this case, this woman's husband, David, says he doesn't want to be with her anymore, right? And she thinks because of that, I feel really sad. I am not able to do what I need to do. I might even be having physiological responses where I feel like I'm moving more slowly, talking more slowly than usual. And what Beck and what Ellis say is, no, it's your beliefs. It's your beliefs about that situation that create those automatic thoughts that lead to these consequences. And so because you believe you're unlovable because of what David did, that's why you feel so crummy. If she was, and he kind of says this later, like if she was able to flip it and be like, well, maybe David's just an a-hole, right? Then you don't feel so bad about yourself, right? And so it's helping people to sort of see beyond those things. So this whole idea is about creating more functional beliefs and behaviors. And at this point, and again, the name of my conference, the Association for Behavioral and Cognitive Therapies, these two models have merged. So very few people would do purely behavioral therapy beyond like applied behavioral analysis in these days. And both Beck and Ellis argue that their therapies always had a behavioral component. They were always like getting people to go out and do things. And so now these therapies are cognitive behavioral therapies, or Ellis ended up changing the title of his to rational emotive behavioral therapy. And so by harnessing essentially the best of both of these perspectives, we can be really effective at helping folks. These are very widely accepted and they have a lot of empirical or research support. And so this is what I am trained in, is in cognitive and behavioral therapies. A lot of modern graduate programs are training their folks in this. And again, I went to a whole conference about research related to this and applications related to this. And so this is one of the most used, most supported models. And so how do we compare these various types of talk therapy or psychotherapy? Well, part of what we can do is look at the cause of the problem. What are they saying causes the person to feel badly, to act in dysfunctional ways? And in psychodynamic therapy, they're saying there's these deep-seated, unresolved, unconscious conflicts going back to like the Oedipal complex and the oral stage and the anal stage, right? In humanistic therapy, they're just saying like something's keeping this person from functioning at their optimal level. In behavioral therapies, the client has learned, right, through basic learning principles, these maladaptive behavior patterns. And I don't really like the term inappropriate here, because it has like a weird connotation, but the client has developed irrational thoughts or self-defeating thoughts, right, in cognitive therapies. So the therapy emphasis for psychodynamic is discovering those underlying unconscious conflicts and trying to get the client to develop insight. In humanistic therapies, you're trying to get that person to realize they have the potential to be an amazing human being. In behavior therapies, you're essentially using learning to change those maladaptive behaviors. And then in cognitive therapies, you are trying to get them to dispute those irrational thoughts, change those feelings and behaviors by changing your thoughts or how you think about situations. So psychoanalysis One of the things that's not on this chart is that psychoanalysis is often very open-ended. So true, pure psychoanalysis, like what Freud did, and some people still do this, is like 4 or 5 sessions a week for years. As you can imagine, a lot of times insurance is not going to pay for that. So a lot of these people will pay out of pocket. In humanistic therapies, again, it can be like very sort of I want to say unregulated, that sounds sketchy, but like there's not like a certain time frame, right? So you are, reflecting, using empathy, trying to help that person to be able to do this on their own. And then behavioral therapies, you're going to give specific advice and actually oftentimes do behavioral things in therapy together. And then in cognitive therapies, you're going to have conversations with the client. You're going to have them do homework assignments related to what's going on to help them change those irrational and self-deflating beliefs. Alrighty, so I'm going to skip ahead a couple slides here because we have an assignment. So if y'all type in tinyurl.com/who therapy, or if you're following along on the Google slides, you can just click this link. So what I'm going to do is so that I can pull it up, I'm going to copy and paste this and put this at the top of the document itself. There we go. And so everybody go ahead and follow this URL. I will throw it in the the Zoom chat too. And then what I'm going to do is divide folks on Zoom up into 4 groups. There are 5 groups altogether. My folks in person, you'll be group 5. And for this assignment, what you're going to do is each group has a very short description of a client. So using our other material we've learned throughout the semester, figure out what disorder this is they have. Follow this link. So this is Division 12 of the American Psychological Association. And these are the list of diagnoses for which we have therapies that work. So for some reason, some of these will just say no excerpt. That's fine. You can still click on them and see the therapies that work. So for generalized anxiety disorder, here are the therapies that have empirical support to say that they work. And as you can see, sometimes they'll only have a couple. Sometimes if we click on things like panic disorder, we'll see more. Let me find depression. If we click on something like depression, there's going to be a giant list because we know the most about depression. Okay. So you're going to use that to figure out which therapies would work for this diagnosis you've diagnosed your client with, and then what therapy would you choose if you were the therapist. So we'll use the 8 minutes left in class for y'all to start working on this. And then we can keep working on this on Monday and walk through it together. So I'm going to do breakout rooms, and then Sammy and Sadie, you are group 5. So everybody will have 3 to 4 people in the groups, and your assigned room number will correspond with your group number. So if you're in Zoom room 1, that'll be group 1. Yeah, you can list all of them. You could even just copy paste if you want. And then question 3 is kind of like the strongest. Oh, I'm like talking and moving. I'm gonna bring everybody back. We'll wrap up and then first thing Monday, we'll release. Alrighty, welcome back, everybody. So what we're gonna do is on Monday, first thing, we're gonna go over people's results from this. I think group 1, none of you typed anything, so maybe you could do that now. And then also on Monday, y'all are going to do a therapy role play where you go to play the role of the therapist and the client. That is going to be much easier if you are here in person. So I'm going to highly recommend if you are able to, I know some of you are sick and some of you have family things going on, but if you are physically able to, please be here in person. It'll just make it way easier. Alrighty, have a good weekend. And again, thanks for your patience with me this week.